anomalies, detection dilemmas, and decision making. We have the moderator with us on stage, Dr. Suresh Sesatri, the founder and director of Legiscan Systems Chennai, a pioneer in fetal medicine with years of experience. He has been honored with the FRCOG London, the Doctor of Science by India Medical University, and he serves as the Treasurer of ISHO of UK. His lifelong commitment to advancing fetal medicine, nurturing the next generation of specialists, and setting new standards of clinical excellence truly makes him an inspiration to all of us gathered here. His immense contributions over the years has shaped the growth and excellence of the specialty in our country. Thank you, sir, for doing this panel discussion. And we have the panelists, Dr. Pratibha Radhakrishnan, Director, Bangalore Fetal Medicine Center, Dr. Rafika, Senior Consultant Obstetrics and Gynecology, KIMS Trivandrum, Dr. Femita Paunami, Senior Consultant and Academic Coordinator, Department of Neonatology, KIMS Trivandrum, Dr. Deepthi B, Senior Consultant Laparoscopy Surgeon, UK, Dr. Kartika Mohan, Consultant Fetal Medicine at Cosmopolitan Hospital, Trivandrum and Government Medical College, Trivandrum. Over to you, sir.
Good morning. Okay, so
Savitya here, sir. Can I just request all of you to join back so that we can have a smooth running of the panel, because this is one of the most important panels, because we need to know how do we tackle those anomalies which are detected late, and we won't have a better person to tell us that other than Suresh sir. So please join back and listen to the panel. I request everyone to come back with your coffee.
Coffee will be stimulating. Okay. Thank you. First of all, welcome to this panel discussion. I have to tell you, before any lecture or meeting, they ask us to declare any conflicts of interest. Okay. So here, there is no conflict of interest. I'm going to declare that even though I know these panelists, but for this panel, I'm meeting them for the first time. So we have not had any internal discussion or anything like that. It's sort of an open panel going to happen. And we have a neonatologist. I always love to have a neonatologist in the panel, because we can simply say, can I deliver and give the baby to you? You take care of it if I see an anomaly. Right. So when I say late onset anomalies, that I say conditions not apparent on early scans, only detected in the late second and third trimester, could be because of delayed development of certain organs, or it could be a subtle presentation or missed on early scans. So, what anomalies are usually seen late? It is something we can, ultrasound has advanced to such an extent that we have brought down, inverted the pyramid of prenatal care, bringing it down to the first trimester. But still we have the option of the second trimester as probably the best scan for looking at anomalies. Now, beyond that, if I've done a fantastic first trimester, second trimester scan, why do we still see anomalies? That's my own thing.
I think you've already answered that question in your previous slides, where because either the organ is so small that you don't see it evolving, or it could be the evolution embryologically develops only at that stage, and the third possibility is there could be external factors that could alter the utero milieu and change the presentation as well.
But the truth is, when I say anomaly, all malformations are defects in embryogenesis. Embryogenesis is completed at 10 weeks. Why are we not seeing it early?
Because they still have to grow. It's not only formation of a cell, but the cell has to grow to an extent to be able to be visible to the human eye in the ultrasound as well. So it's hyperplasia as well.
Okay, so let's move from there and then straight away move to case, because we have a little time and we need to cover as many cases as possible. She's a 27-year-old G4. She's got two missed abortions at 2 months. She's hypothyroid and one baby is doing well. Referred at 19 weeks for a target scan.
the lateral ventricle on one side is 11 millimeter, which is a mild ventriculomegaly, and the other side is 6 millimeter, which is within normal limit. But at 19 weeks, with the history of previous two wrist abortions, I would like to offer genetic testing.
You would like to offer, no, but first I need a diagnosis, isn't it? So what do you think? Is there a problem here? Do you think there's a problem here?
Right now, it's not a problem, but it may progress. 10% of cases, it may progress.
So if you think there's no problem, why should we do testing?
Some cases, there is no problem, but in some cases, it may
Okay,
progress.
I'm going to tell you that she's had a very good first trial, but screening, and screening is definitely negative. Would you still want to investigate, or you just want to get that for a repeat scan?
Yes, I still want to go for a repeat scan after 2 weeks to assess the
I
progress.
have other parameters, if you want to take follow this.
So we have mild right ventriculomegaly here. So I think I would definitely want to evaluate her now itself and then keep her on a close follow-up. So we can go ahead with the TORCH screening and maybe a microarray. Even if the screening is done in the first trimester, that's only a screening, it's not diagnostic. So I might want to be a little bit more sure because it's a ventriculomegaly and it can progress. So I want to be on the safe side.
Okay, so 11 millimeters, it has now been declared as abnormal by both my other panelists. Pratima, you follow?
I think firstly I'd like to know whether this is isolated or whether this is associated with any other anomalies at this time.
Okay.
It's only a referred thing. So particularly intracranial, there is a posterior fossa cyst
Well,
that needs further evaluation.
we felt, you can see the cerebellum is normal.
Sorry,
The cerebellum is normal.
cerebellum,
So the deep angulation.
but will need further assessment because it could be a BPC, it could be Dandy Walker, it could be something else, and already it is associated with another intracranial sign.
So we have declared that this is a BPC.
Okay.
It has come as a BPC.
So you have BPC and mild unilateral ventriculomegaly. So you have two markers.
Right. So, as you expected, that this is an isolated unilateral mild ventriculomegaly. And do we investigate? So she's already asked for investigation. She wanted a microarray. She's already said that. But what do we tell the parents at this point? That this baby will, supposing the investigations come as normal, are we going to reassure them that everything will be normal?
We are not going to reassure everything is normal because this ventriculomegaly may progress in 10% of cases. But in majority of cases, isolated ventriculomegaly is having a good prognosis.
So, at present, we rule out infection, we rule out microarray, and do we need to do whole exome sequencing? Do we need to do whole exome sequencing? Not at this stage.
Not at this
So
stage.
you don't say microarray we will do that. So we do have what is called the 10% rule. 10% will progress, 10% will have chromosomal disorder, and 10%, there is 5% genetic disorder, 5% infection. All that is ruled out, and we've done everything whatever we need to do. So we follow her up in 2 weeks' time. But then she said, okay, you've reassured me so much, and let me take it easy. And then she comes back at 29 weeks. But 2 weeks is too early, isn't it? So tell me, it'll be good to know that once you've seen an 11 millimeter on one side and you've declared everything as normal, is it the fetal medicine specialist anxiety to call them back a little earlier, or is it really required to call them back as quick as doing that? But I think the mic is working. Mic is not working. Can you give a working mic, please? Yes. Yes, you got it.
I thought brain is something that is evolving all the time. maybe the brain can look different. So I think if you really want to, once this has been sorted, there's no infection, there's no chromosome, there's no CNVs, and hopefully they've stored some DNA as well. ESS for at 26, 28 weeks, because that is when you will start seeing the next level of brain anomalies, because that's how the brain evolves. So state, third trimester, late second, early third trimester would be my neurosonogram.
Okay, so 2 weeks is too early. So she comes at 29 weeks. Okay, and this is what we see. Now we have come to the realm of the obstetrician and the neonatologist. Because both of them, this baby sort of come to the period of viability. And here, first let us get the diagnosis from them. So what do you think now this baby has?
Mr. Director, again.
Please speak louder into the mic. Is that? Do we all agree that this baby has got significant ventriculomegaly now? The last ventricles are dilated, the third ventricle is dilated, significant ventriculomegaly. Now, it's a very different thing altogether, and this patient comes back with a report of bilateral, significantly dilated lateral ventricles with dilated third ventricle, and she comes to the obstetrician. What would you tell her?
Parents will be worried about the situation right now. There will be many questions in the minds of both parents as well as the obstetrician. So any decision that is taken would be based on the neonatal survival, the long-term survival of the baby, the quality of life of the baby, even if it is to survive. So these will need definite answers, and prognostication will depend on, now that it is bilateral, significant ventriculomegaly.
So you gave us a very important term that we need definite answers. Right? The parents also want the definite answers. Who's going to give us the definite answers? Is the
Existing
treatment
data?
going to give it?
No, the
Or is the neonatologist going to give it? Or we have to call a neurologist and neurosurgeon to give it to us? Who's going to give us?
On the basis of the available data that we have, we can prognosticate it because it's bilateral, it is a significant ventriculomegaly. We need to look for any associated brain anomalies. When
Yes.
these are present, definitely it carries a guarded prognosis.
Okay. So associated brain anomalies. We've already investigated her with all the other infections, karyotyping, everything is ruled out. Associated brain anomalies beyond this excellent ultrasound we have done. Do we need to do more?
Digital MRI definitely at this stage would be helpful because some cortical malformations may be missed by an ultrasound. We can check the periventricular area as well in MRI.
You asked for an MRI. You have done a very good ultrasound transcript.
At least the neurosonogram.
Fantastic. Still what? You're the one.
I wouldn't do an MRI. I think a good transvaginal neurosonogram will give me all the answers in this.
Neurosonogram, or if a good neurosonogram is not available, an MRI.
MRI. Okay. So, but essentially now, she is now 29 weeks. The patient is requesting for the termination of pregnancy. Should they?
So that needs a combined counseling including the obstetrician, fetal medicine specialist, neonatologist and the pediatric neurologist to discuss about the long-term prognosis of the fetus.
That's what I'm saying. When you say discuss about, they want to know definitively whether this baby will do well. Who is going to reassure them?
Nobody knows whether the baby will do
So
well.
that's why nobody knows. They say she's 29 weeks. Now, I don't want to go through pregnancy. Tell me what options do I have.
If they are insisting termination of pregnancy, they should get the consent from the state medical board. Most of the time, as it is a non-lethal anomaly, they won't get the permission from the medical board.
Yes.
So sometimes people are going to court and getting special order for termination, even up to late third trimester.
Okay. So the medical board denies them the the examination. The court also said, medical board has said, I'm not going to give you permission to do that. What option do they have? As a neonatologist, they're going to come to you and say, this baby is delivered, you're the person who's going to take care. And what are you going to tell them?
Sir, if the baby can't be terminated for a non-lethal anomaly, then I prefer the baby stays in utero because we don't want added on preterm brain injury over and above this.
So you don't want to be in a hurry to deliver. Okay, let it run through its course. Okay, so the dilated third ventricle MRI has been done. As you did not want the MRI, they went and did the MRI. MRI is considered to be normal. And normal means that no other, apart from the ventricle. That was the given. It's beyond what is there. So the final diagnosis was accidental stenosis. Now we come back that we have a firm diagnosis of accidental stenosis. The outcomes obviously, if the person comes with a diagnosis of accidental stenosis, because so far we only been telling ventriculomegaly, but now we have a definite diagnosis of accidental stenosis. So would you talk to them differently if it's an accidental stenosis? Would you tell them something different? Neonatologist, you should tell them.
We've seen reasonably good prognosis now with aqueductal stenosis, which you've diagnosed early and before it can cause obstructive hydrocephalus. Even endoscopic third ventriculostomy is working good, sir. So if we have a definitive cause as aqueductal stenosis with no other anomalies in the brain, then as a neonatologist, I would encourage them to proceed with the pregnancy and hope for the best.
So, if you look at the actual evidence, we find about 30% of them can have normal developmental outcomes. Certainly more than 70% will have other issues, their developmental delay or other thing. And this was one of the reasons why in utero shunting was given up many years ago for this condition. So this girl may be delivered at 38 weeks because, as you said, we do not want to deliver her early. A VP shunt was done at 1 month. And the developmental milestones are absolutely appropriate for gestational age. At 1 year, 1 month, the child was doing well, and this is 4 years old now. We were able to follow it up to 2.5 years. And after 2.5 years, the child is doing absolutely well. Now, going back, if another patient comes to you exactly the same finding, would we say, okay, now this baby will do well, you can do a shunt postnatally and do well. So what will be our counseling? We have learned a lesson from this case, but what will be our counseling for a future case like this?
Every case is different, so we still go by the guidelines.
So in other words, your counseling is always going to be, I am not sure. Correct? I am not sure. Right. But let me take through the next one. She's a low risk priming target scan. Okay. Interpretation. Which is last one? Just to show some lichen and mouth and nose, that's all. So purely we are dealing with the brain, nothing else. Looks normal, isn't it? So why are we hesitating so much to say normal? Because whenever you put in a panel discussion, there has to be some abnormality there. So what I'm trying to say, this is normal. 20 weeks, absolutely normal. So when will you call her for a repeat scan? Normal. Lowest training. 28 weeks, 32 weeks, 34 weeks.
For uncomplicated primary after anomaly scan, usually we call for the scan near term only, 34 to 36 weeks.
34 to 36
To
weeks.
look for fetal late onset growth restriction and also to pick up late onset anomalies.
Okay. Does Fatima agree with that?
There's a lot of obstetric input when it comes to routine third trimester scan, but of late we have started doing it at 28, 30 weeks.
So is the third trimester
Third
scan?
trimester scan.
Is the third trimester scan traditionally called as a growth scan?
I think we should change the
do
terminology.
we actually do anatomical evaluation of the third trimester?
I think it's time to change the terminology
Yes.
of a growth scan because it leaves a lot of misconception that it is only to measure the biometry and maybe the fluid, and if you're lucky, then maybe a doctor also.
Yes.
But it is much, much more than that.
Yeah. So you still feel that we do anatomically evaluate the baby as that in the third trimester? Right. Now she comes at 37 weeks. And that's what has happened. Now, the questions the parents ask is, why did you not do a scan early? You never told me. If you had told me, I would have done another scan.
Certain anomalies present late, even if they had done a scan earlier, we would not have seen this sometimes. So,
Oh, but now let's go back to our first case. When we said ventriculomegaly, immediately it triggered off a series of investigations, right?
this one didn't have a ventriculomegaly in the target scan.
A target scan. But now, ventriculomegaly, at any point of time it has to trigger investigation, isn't it? So, does it warrant investigation before delivery? Or how are we going to counsel this patient because we are stuck at 37?
She said 37 weeks near delivery, right? So we will do investigations only after.
So, what are we going to tell the patient? Are we going to
This
say
isolated ventriculomegaly is associated with the prognosis.
Okay, the question comes now is, will you allow her to go for spontaneous labor, vaginal delivery, or because there is a problem here, you want to, is there a goal for electrolysis section? Or if she is there a role for saying that somehow I will deliver vaginal delivery?
So she needs only standard obstetric care and near term.
So irrespective of the anomaly, you're going by what the obstetric course is going to become, right? So like, now what happens here is, we are going to treat her exactly the same way as we did before. In other words, a 20-week target scan, how much reassurance we can give the patient. Leave it on ventriculomegaly. Any other thing that would happen. What percentage of anomalies actually happen much later apart from the target scan?
1.5%.
Around 1.5 to 2% of anomalies will happen later, while majority of them will do well. So naturally with this isolated ventriculomegaly, if it's truly isolated, then there's good outcome at over 90%. It certainly needs extensive assessment, and the most important is document the facts. We'll go on to this next case now. We'll come down at the body, and then she's 13 weeks one day, third degree consanguinity. Her sister's daughter had a cardiac anomaly, wants reassurance for normalcy of the heart. It's the first time this came. What's your take on it? Now, how normal? So when I say she is asking specifically for reassurance of normalcy of the heart. So what will be the specific words you tell her? What have you seen at the heart and how much of the heart is normal?
At 13 weeks, it's very difficult to evaluate the heart in full detail. So we have seen what is possible at this time. We will re-evaluate her at around 16 weeks. And
You want to call her back at 16 weeks?
yes.
We'll come to that. So now, first trimester cardiac, you will say that there is anything you want to say? The stomach will on the right side is normal, everything is fine. So you have the inflows and outflows which are there. So should she have an early target at 16 to 18 weeks? Do you believe in early targets? Yeah? For a heart. No, in this case we are specifically looking for the heart. So at 16, can I tell the woman that this heart is normal?
What you can do at 13, you can do at 16. You can do much better at 20. So I don't think there's a great deal of difference between a normal appearing heart between around 13 weeks, a well-performed.
So that early target is really for my reassurance.
It's more for reassurance, yes.
Right. Okay. So why can't we just push straight to say come back at 22 to 24 weeks, then we have a good look at the heart and then
An echo.
echo. Okay, right. So she comes at 20 weeks and 5 days, and these are the features. You can ask me whatever questions you want.
I might want to go back and ask her, what was the cardiac anomaly in her sister's child?
Oh, Fallon's.
So,
Fallon's, yes.
and he had a family history consanguinity.
No. 30.
This heart looks okay to me. Heart looks okay to me, but we can still follow up.
See, you told her you come back at 20 weeks. She is wanting reassurance. You have reassured her. He said, I can't reassure you at 20 weeks. Come back at 16.
I won't reassure her until the baby is in the hands.
Then what is the purpose of doing so many antenatal scans? Right? That's not fair, is it?
In 20 weeks, the targeted anomaly scan says the fetal echo is normal and the rest of the organs are normal. Can reassure her.
So in other words, we would like to know, are there any cardiac anomalies that are going to develop much later, which simply I can't see now?
There are anomalies which can evolve or even become it late second trimester and third trimester.
What her worry is, if her worry is whether her sister's kid had fellows, and if I see a heart like that and I have demonstrated a good left ventricular tract, I can look into her eyes and say, there is no fellows.
So,
But what I cannot exclude is the evolving stenosis, pulmonary stenosis, aortic stenosis, cardiomegaly, but these are probably 5% to 10% max. But I think a good scan at this stage with no markers for cardiac defects in the first trimester is reasonably reassuring. If she wants reassurance, I'll reassure her for now.
so that's good. So that means you can do specific reassurance of, if you know of an anomaly that happened in the family, you can definitely rule that out now. Then you can say, I have ruled out Fallon's. So that gives them some degree of reassurance. I think most of the time they are worried whether a similar cardiac problem is going to come. So, do we all agree that this scan is absolutely normal and she can say, okay, today everything is fine, go back home and sleep. Right? Okay, so she was informed the heart was structurally normal, no major anomaly detected, and she was reassured. And repeat scan. Okay. It's my biggest problem. My biggest problem is when to repeat the scan. Last time we were repeating the scan for the sake of the brain. Now we want to repeat the scan for the sake of the heart. So between 20 and 28 is some anomaly going to evolve, or it's going to be at 32 or 34. Your pulmonary stenosis, whatever you want to say, I think.
In uncomplicated low-risk pregnant women, after detailed anomaly scan at 20 weeks, like to repeat a scan at
So
34
is
days.
she a high risk category or a low risk category? No. As a patient now, if you classify her under high risk or low risk?
Low risk.
So the low risk 2 scans, also normal, she considers low risk. So can we get her at
34 weeks is reasonable.
32 or 34?
34.
Okay, right.
I just like to highlight this to the obstetricians particularly because the later we go in pregnancy, anatomy assessment can become sometimes challenging. So I think for me 32 is a good time. And because after 34 the baby doesn't turn around much and you've got the bones which are much
So the
more
baby is
calcified. Baby is
but it
bigger
is
and
fine
so
and easier.
if I have to see the heart, like the way she wants me to see, and I'll be thinking in my mind coarctation basically. I want the baby to be looking up, which can become a challenge at 34, 36 weeks. So I think fetal medicine people should be allowed to make that decision when you reassess.
Then will you repeat again after 1 month?
there's nothing wrong in repeating the scan.
Because
But
the
if I
baby-
have to specifically look for the heart, then I would like to do it at a time that I can see the heart better. And if I have to reassure the mother, then I would like to reassure.
It again, so it's
So let me ask the obstetrician. A baby at 32 or 34, whatever it be, are you happy with the occipital anterior position or an occipital posterior position? Can I ask?
In getting the scan done, sir.
Yeah, not for scanning. I'm telling in terms of presentation.
Yeah, occipital anterior positions are associated with easier deliveries as
Easier
compared to
delivery.
occipital.
But that's the nightmare for the fetal medicine specialist because the spine is completely anterior and you can't get the heart. Right? So now, 32 is what she prefers, 34 is what he prefers. Yeah, 32 scan is better. Okay. So she comes at 30. Okay. And this is what we see.
multiple epidemic lesions are seen in the heart, probably anomalies.
Yeah, rapamyoma. Okay, so 30 weeks rapamyoma. The patient is now going to ask you, doctor, are you sure that you didn't see this at 20 weeks? You
We can show her the
rapamyoma present.
pictures, we can show her the images, and say that we are very sure we didn't have a rapamyoma. At that time it was visible.
Okay, so
Maybe
now
this
what
time.
next? Now what next? This anomaly is now identified. What's the course of action you want to take?
Myomas are associated with healthy conditions like tuberculosis, so we can offer prenatal genetic testing at this point of time rather than waiting till delivery.
Okay, that brings us to the question of prenatal genetic testing. Okay, my question is any additional imaging required? And that question we have answered why it's not starting again. So, what are the implications of this to the fetus at this point of time? Dr. Mayam, what can happen?
I think once you have a multiple rhabdomyomas and you think of tuberous sclerosis, you need to do again a neurosonogram, and here I would like an MRI because an MRI.
So you want additional imaging at MRI?
neurotypes at this stage, and definitely a genetic consultation before I do anything.
Genetic consultation.
Genetic consultation,
So
because
will-
we need to evaluate the family now.
Yes.
And now I'm even more interested in the cardiac anomaly in the sister's skin, because whether there was something like
In
this
the
there.
family. Yeah. So now two things come to the fore. That we are going on a different course of diagnosis now. That we are actually looking for a genetic disorder, and which means I have to do an invasive test at this point of time. The genetic says, okay, you have to go and look, there's an association of tuberous sclerosis, so you need to do that. At 30 weeks, do we still do prenatal diagnosis? Or simply store the DNA and say, let me do the testing later on?
The multiple rhabdomyomas, late onset, and if there is a history suggestive or if there is brain findings, that is pretty much diagnostic of tuberous sclerosis. So I don't need to do any more genetic testing, more prenatal diagnostic. I don't need to do an invasive here. I think so. I think, of course, this can change sometimes. But if there is a clear-cut history driving towards tuberous sclerosis, but even that, if there is again a family history of tuberous sclerosis, many times the father, we have had situations where the father who's never come to the antenatal clinic actually has got tumors in the brain.
Signs of
And that is how it has been passed, and it's not through the mother. And in those situations, if they have a live person there, many times the parents are inclined to continue with the pregnancy and not terminate. That's and many of these rhabdomyomas will subside as well.
Okay, so let me push the word to the neonatologist and ask her, have you actually come across a baby delivered and then you found rhabdomyomas?
Yes, sir.
See that?
Antenatally and postnatally, for the first time, for a doctor baby, we found a cardiac murmur on day 1 on routine examination, and it turned out to be a rhabdomyoma.
And was not diagnosed antenatal.
It was not diagnosed.
Okay,
And the baby otherwise good. And it is a proven tuberous sclerosis. There's no other family member. Because we know about it. The other two or three which are coming to my mind are all antenatally diagnosed. But again, went on to continue pregnancy and are doing reasonably well. These are not lethal anomalies.
But you do have drugs now, isn't it,
For control of epilepsy.
for
For
the
the heart, we haven't, at least during the gamut that we see, sir, in the first 3 or 4 years, we have not had to use any drugs for the heart for the rhabdomyoma causing issues.
Okay. Okay, but I thought there was drug for sirolimus. You can give antinatally.
It has been that, if there is no obstructive lesions in the heart, like, in fact, I have one, that kid is now almost 15 years old, huge, completely filling the left ventricle, but still had no obstruction, and just over a period of time, it just subsided.
Yes, sir.
And the mother had the lesions when she went to the
So
general.
really the indications for
So, we have not
initiating
used
treatment
any
is
medication.
obstructive to reduce the size.
So, yeah, there have been some studies, but it also depends upon the site. We've had one with block also, because it was affecting the.
So, is there any specific location which we need to look for in the heart, or they can come anywhere? The rhabdomyomas, is there any specific location or in the Sunday?
Sinus node
Yeah.
pathway, that's when it can affect the cardiac rhythm,
Yes.
and that's what we have seen actually. Others have not really.
So the atrial rhabdomyomas are a little there, the ventricular rhabdomyomas are a little bit more common. And it certainly can cause, in the atria, if it is there, it can compress on the coronaries and cause cardiac ischemia. Okay, natural course in utero, you said they can regress. What are we concerned during the follow-up? With the follow-up, they can increase inside the utero and they can cause chemotherapeutic obstruction, that's what she said, I can even go to high dose. So what evaluation would be needed now? Now genetic testing. That said, she said she's not going to do it in antenatally. She'd rather wait for the baby to deliver. So the baby comes to you now. Right? And when you do genetic testing, the baby is born, it is given to you today, do you immediately send it for genetic testing? Or that's the thing you say, I'm not really concerned about it now. Let me see whether the baby is okay at this point in time.
Totally depends on the family's choice. Very well-informed, very anxious family who want to have answers as early as possible. Then we do allow them to meet Dr. Roshan and genetic people and then take it from
But getting an answer saying that this is tuberous sclerosis, is that going to change your line of management?
No, sir. So the initial part, which is our priority, is feeding, getting a bond between the mother and baby, and if they seem to be okay to follow up and do it later.
So she does not want it antenatally, you do not want it postnatally.
Do, sir.
Why are you even talking about it?
We need it for some anticipatory guidance we do, how this baby is going to do later, and to plan his or her follow-ups.
Probably for future pregnancies.
Also.
For future pregnancies we can get that. Okay, right. So when we look at the history and we put that, this is where the value of genetic testing actually comes. We sent her to the geneticist, he said, I will send her to the geneticist. They took a careful history. And remember, when you take history of patients, the first person who takes the history, a lot of times that information will not be complete. The second person who talks to the patient who is probably a little bit more better getting the information out, then some more information out. This mother initially said everything is fine, her family is fine, everything is fine, but then finally she told, my heart also had a problem when I was born. And she had a rhabdomyomas. Child, it regressed by 15 years of age. MRI for the mother showed cortical tubers, and ultrasound also showed an angiomyolipoma of the mother's kidneys. So, the genetic counseling, obviously whole exome sequencing was done for the mother, follow-up cardiac assessment in 4 weeks, neurologist consult, the mother is consulting neurologist for the first time, right? And she was otherwise all right. So she didn't go for consultation. Again, she did not have any neurological sequelae, but potentially it could be there. Right. Now, the delivery part itself. Do you need a cardiologist team to be there, or as a neonatologist you can take care?
At delivery, there's no feature of high drops or cardiac failure ultimately, and we could manage.
Because I always find out that when I talk to neonatologists, whenever a baby is given to them, they don't want to give it to any other specialist. They want to stabilize the baby, and only when you are ready to give to somebody else you do that. Same principle we can apply here also, isn't it? And then postnatal echocardiography is there, and then we will, all right. Then the parents are asking, will my child need surgery if I know what I need to be brain? So the answer usually is most cardiomyopathy are asymptomatic, natural history is spontaneous depression, 2 to 5% with cardiac failure, may need surgery, and high risk candidates, of course, when surgery is needed. So let's go to case 3. Okay. This is a 28-week growth scan. Target scan was absolutely normal. A detailed fetal echocardiogram was done during target scan by a specialist, and they declared it as normal. So she comes at 28 weeks, and this is the image I'm getting. Any comments on that?
It's like a perimembranous VSD.
Looks like a perimembranous VSD. So let me give you some pictures there.
It's not VSD,
Perimembranous VSD. There's an overriding. So will your counseling change if it's perimembranous VSD or if it's oral?
Sorry, I just call it malaligned VSD.
Malaligned VSD. Okay. So here's a late presentation of malaligned VSD, and the final diagnosis of the perimembranous septal defect of 3.9 millimeters, normal irregular rate versus normal rate of rhythm. So how to communicate this to the couple? The question automatically will come, why was this discharged? Because a pole suddenly did not develop. The hole was there. It cannot suddenly, a formed septum cannot develop a hole inside. So, and would an early diagnosis have changed the approach? So, there are a few things that happen now. I have found out a cardiac problem. Simple problem though. Does it trigger a set of investigations, even though it is late? Is that going to help me to decide further about it? Do you investigate? Any invasive testing to be done?
For any other anomalies, everything is fine and isolated, small perimembranous VSD, doesn't warrant any more investigation.
So, are we going to reassure the patient that this baby, don't worry, can be taken care of? We'll check whether everything else is all right. If everything is fine, relax. Because the real answer to this question is going to come from the neonatologist. How many times have you seen in your practice babies born with absolutely normal scan report and VSD is identified in your unit?
Several times.
Several times. So that
It
means
happened not just, even we would visit and we would pick up, and we would pick it up at 4 weeks, 6 weeks when they come for the first vaccine.
so even the neonatal period you can miss and can come back after 4 to 6 weeks they didn't happen. How can that happen? You done an echo.
Echo, sir, we understand. If it was picked up annually, we might have checked for it postnatally. If it was not picked up annually, we can still see it.
So all babies who come to the NICU don't get an echo.
No, sir.
Okay. unless you feel there's a murmur or something. Only then they go. Right. So the question now is, she has said, in spite of very good ultrasound being done accurately, she is seeing babies which are, you identify BSD later on, right? So in which case, when you communicate to a couple, are we going to say, I've done a good scan at 20 weeks, I don't find anything wrong with the heart, but occasionally small BSDs and things can get missed. It must be half the size, exactly. It is 4 millimeters, now it must be around 2 millimeters at the time.
We have the problem the other way, where there are 1 millimeter VSDs being picked up which is not there.
Exactly. So why I'm asking this question is, the first thing we have seen in neonatology, or in some, not specifically with you, I'm saying places, the moment they find something wrong with the baby, oh, was this not picked up before? Did nobody tell you? No, I told you, I made a disclaimer. It's not you. I'm saying, so this is a practical issue which we need to really address. That what should be the first reaction when you find a baby with an abnormality which is detected late or at after birth. So the first thing, and this patient might have gone from, the first scan might be done by one person, the second scan might be done by another person completely, and this is what we need to sort of clarify, right? That we need to be very responsible in the way we talk to patients, because the first person who is going to give the information that, oh, it was not detected earlier, then their mind goes completely into what happened, why was it not being worked. They are not worried about what's going to happen now. They are constantly asking why it was not happening. And we know what's happening. So since this is the question we have answered, could this have picked up in all cases? Really no. If we had picked it up at 20 weeks, we would have activated manual change. Will you do invasive testing now? See, as a fetal medicine specialist, I feel Pratima is very hesitant to do invasive testing. Tuberous sclerosis also, you said, no, I won't test now. BSD also, well, I'm not sure.
Deciding yes or no. I think we need to look into the details of the case. We have to individualize, especially when we are doing late prenatal testing, invasive testing. There are so many things to be considered because
if you do testing now and it turns out to be trisomy 21,
you're not going to get permission to stop this pregnancy. It's only an information that the patient will know that there's a trisomy 21. That's about it. Nothing
so
more.
I think there are a lot of times spontaneous closure certainly is possible. These are not things which are going to be in a hurry to do. Okay, so I think we will stop here at this point because we have completely run out of time. So thank you, panelists, for this engaging discussion. And can we just